Students, we are going to start a very important class. I am Dr. Vikash Goswami. I am going to take you a class on cerebrovascular accident. It is very important for your learning, for your practical practice, and also in your exam. Very important. You are very much expected that you will can get a case of left-sided hemiplegia. Then everything in your practical classes will be asked about cerebrovascular accident. At least basic things you should know. So, term is cerebrovascular accident. We are start with the term that it is accident. Accident means it is a sudden onset, and progress may be different, but onset is sudden. Sudden onset means we can see there is the maximum neurodeficit. Cerebral accident is a neurodeficit. It is a deficit in neurological system causing the paralysis. So, this neurodeficit may be sudden in onset, maybe maximum at the onset, maybe not maximum in the onset, but it will be gradually progressing within 40 to 72 hours. But most of the cases, we come to the next slides and see what is the difference between hemorrhage and thrombosis. Suppose in a cerebral hemorrhage. Example, this accident, this onset is very sudden, and the maximum symptoms of the neurological deficit will develop at the 0 hours. Then it can progress, it can reduce, that is a separate issue. But onset is maximum neurodeficit at the onset. It is in cerebral hemorrhage, but not in the case of cerebral thrombosis. Cerebral thrombosis is what happens, it is also a sudden onset, but maximum neurodeficit is not at the onset. It gradually progresses to 48 hours or 72 hours, or it may improve, it may deteriorate, that is a separate issue. But maximum neurodeficit at the onset, sudden onset is in a cerebral hemorrhage, because these questions will be asked in your exam. Why do you call it is not thrombosis? It's not that you are giving a CT scan, you have to guess it is a thrombosis or hemorrhage. So accident is that. Another is embolism. Embolism is also a sudden onset. Not like hemorrhage, it is a sudden onset and maximum symptoms at the onset and gradually progress or gradually deteriorates. So it is an accident, sudden onset. Then it is a vascular. Vascular means that onset, this incidence is due to vascular origin. Maybe patient may have a SOL in the brain, can have progressive paralysis, but that is not CVA. Cerebral vascular accident. That paralysis is due to separate reason, but vascular means it is a vascular origin, some obstruction in the vessels. It may be, most of the cases it is arterial, but venous obstruction may also call stroke in rarest rare cases. So, it is a vascular origin, second. Then third is cerebral. Cerebral means I have already told it is a neural deficit. Some part of the brain is destroyed, so some neurological deficit is manifested in the body, in the either left half or right half or like that. Okay. So, what is the I have already told what is the definition of a stroke? It is the abrupt onset of a neurologic deficit attributed to a vascular cause. Another term is called transient ischemic attack. Here the definition is all neurological signs and symptoms resolved within 24 hours. There is no neurodeficit will be manifested after 24 hours. Without any evidence of brain infarction, the brain imaging. There will be no residual, there will be no damage found in the brain imaging. This is TIA. This question is asked often, this is why it is TIA. And TIA, the CVA, both are maybe recurrent. TIA may be recurrent, suppose this one after 6 months patient has another instance of TIA, maybe that. But and stroke also may be recurrent. TIA may be due to thrombosis. It is not usually hemorrhage, because hemorrhage will not resolve, but it may be due to embolism or thrombosis, which can be resolved automatically. And often this question is asked, why in case of embolic episode, you know what is embolus? Embolus has a separate source. It may be in the heart, maybe in the carotid artery, and that embolus, that thrombus is dislodged and stuck into the peripheral artery. That is embolus. But thrombosis is that the thrombus is developed at the site of the lesion, it gradually increases in size and suddenly obstruct the narrows the vessels and obstruct. So, if the TI, now if the TI is due to embolus, suppose the TI is due to embolus, Is it not? Is it unusual that the same the embolus starting from the heart or from the carotid artery blocks the same artery in the repeatedly? It is unusual because it will go to different arteries. So a TIA, recurrent TIA due to embolus will be at different place. At one incidence, patient has a monoplegia left hand and resolved within 24 hours. And after 3 months, 4 months, 6 months, patient has suppose developed weakness in the different right lower leg and resolved. So TIA due to embolus may be in different place. But TIA due to thrombosis, if it occurs, TIA due to embolus may be at different places at different episodes. But thrombosis, if it is a thrombosis, suppose there is a thrombus develops in the bifurcation of the carotid artery. And on the thrombus, we know the thrombus when forms, there is a stable part of the thrombus and the unstable part. Thrombus is a stable part which remains there, and unstable part which the platelet. Unstable part is common, it is eroded, platelet accumulates, platelet become obstruct the thrombus, and platelet dissolve, and also the thrombus and the blood flow is restored. So if it is due to thrombus, TIA in the same place because the thrombus is at the same place, so TIA may be at the same place. So recurrent monoplegia of the left hand after 6 months. So these things happen. So now stroke or TIA, I have already discussed is that stroke is a ischemic stroke or maybe hemorrhagic stroke. Ischemic stroke may be thrombotic or embolic. Because both are there is cut off blood supply in the periphery. So the basic pathology is there is cut off blood supply. Maybe due to thrombus at the fixed thrombus place or embolus, it is different, it is dislodged and obstruct peripherally. So this thrombotic thrombus, it includes about 85% of the cases. So you will see total there is 85%, and the hemorrhage is only responsible for 15% of the cases. This hemorrhage may be due to mainly there are few reasons like aneurysmal. There is the aneurysmal dilatation in the artery, and that ruptures, becomes hemorrhage, or there is AV malformation, arteriovenous malformation, that ruptures, becomes an hemorrhage, or in that case the subarachnoid hemorrhage. And what happens here? The bleeding is in the subarachnoid space. There is subarachnoid space. In the subarachnoid space means it is not in the cerebrum, not in the tissue of the brain, but in the subarachnoid space. So the subarachnoid space, blood in the subarachnoid space, what is the content of the subarachnoid space? It is CSF. So if there is a hemorrhage in the CSF, there will be raised pressure in the CSF. That raised pressure in the CSF will compress the brain. Cushing phenomenon, yes. That compresses the brain and that will produce some symptoms. There is a mechanism for subarachnoid hemorrhage. So you can call it as a mass effect. It is a mass effect. And hemorrhage can also have a mass effect. If it is a big hemorrhage, can have a mass effect. Sometimes called coning. Coning means the medulla is stuck into the crux cerebri, and there is a medullary obstruction. Though the lesion is not in the medulla, it is in the subarachnoid space, but the symptoms develop due to medullary obstruction at the crus cerebri. This is called coning of the brain, right? So this is a part of the brain. If these things you have already written in your earlier classes. There is a frontal lobe. There is a superior sulcus. There is a sulcus. Front of the sulcus, it is a frontal lobe. Back of the sulcus is a parietal lobe, and there is a backward. There is a parieto-temporal sulcus, separates it from the temporal lobe, and the parieto-occipital sulcus, of the occipital lobe, and there is cerebellum, and there is brainstem. It's corpus callosum. The structure of the brain is behind it is because it's a function of the frontal lobe. What is the function of the frontal lobe? It is a premotor cortex. Motor higher center of the motor is a motor cortex. It is a primary motor cortex. Is anterior to the sulcus. Anterior to the central sulcus is a premotor, and frontal lobe is a higher center for conjugate eye movement. This is very important. It is a conjugate eye movement center. Is a conjugate eye movement. The both eye are moving. If you fix the object, both eye are moving in tandem. So it is a conjugate movement of the eye. And frontal eye field is also responsible for prefrontal cortex for memory learning, and the higher center for memory learning, and is a personality and behavior. And Broca series is not actually in the inferior part of the posterior inferior part, almost at the adjoining area of the temporal, parietal, and frontal in the dominant hemisphere. Dominant hemisphere by means we know dominant in case of right-handed person, it is the left side is the dominant hemisphere. In the left-handed person, yes, not always true. Because in almost all cases, right-handed person has a left dominant hemisphere, but if the patient is left-handed, it has been seen that 50% cases it is the right here hemisphere, but another 50%. So you have seen some bowler, some cricketers who can bat left-handed, bowl right-handed, or bowl left-handed, bat right-handed. So this explains why this dominance in the left-handed domination is not always true, that the dominant hemisphere is in the opposite side. Is only 50% cases true. Anyway, so the Broca's area, is actually the adjoining area in the dominant hemisphere. So Broca's area is a higher area for motor area for speech. Broca's area. Now temporal lobe, temporal lobe, it is a auditory cortex. Wernicke's area, it is a higher center for auditory cortex. Wernicke's area is a sensory higher center for sensory area of the speech. Because when we hear, first we interpret the spoken words, then we do the action. So it is the area for sensory area for speech. Wernicke's area, it is also in the dominant temporal lobe. Wernicke's area in the non-dominant dominant temporal. In the non-dominant side, it is it is also an area which is mainly for recognition of your side. So they may be hemiagnosia, hemi-neglect. You just neglect your left side of the. There is nothing motor deficit, but you just neglect the left side is not my part of my body. The feelings comes. So it is agnosia. These things, the peculiar symptoms develops due to the non-dominant temporal parietal lobe. And parietal cortex, it is a sensory cortex. It is behind the central sulcus. It is a sensory cortex, and also the associated sensations, different sensory inputs are associated. Apart from this, there are occipital. Before coming to the occipital lobe, this temporal lobe, and as there is a visual, the frontal lobe, we have discussed that it is a higher center for conjugate eye movement. This temporal lobe and parietal lobe is also responsible for field of vision. If the temporal, in the case of parietal lobe lesion, you will get a upper quadrantic homonymous hemianopia. Upper quadrantic homonymous hemianopia. I have discussed this. You know this. No? This is a field defect. And on the other hand, in the lesion in the parietal lobe, there is a lower quadrantic parietal lobe. It is a lower quadrantic homonymous hemianopia, and in temporal lesion, it is upper quadrantic homonymous hemianopia. Every word has good meaning. It is a hemianopia, upper quadrantic, homonymous. Homonymous means the same side. That the right side of the vision, right side of the left eye, and left side of the right eye. Then it is homonymous. Hemianopia and upper quadrantic, lower quadrantic. So parietal lobe is a lower quadrantic, and temporal lobe is upper quadrantic. Anyway, then this comes to occipital lobe. Then occipital lobe also, is a higher center for visual cortex. Is responsible for visual, and also occipital lobe has two very important. Some postgraduate, very important. Calcarean gyrus. There is a calcarean gyrus. Calcarean gyrus has two lips, upper lip and lower lip. Upper lip is responsible for lower quadrantic hemianopia, and lower lip is responsible for upper quadrantic hemianopia. Yes? 17, 19. But there is a difference between this quadrantic hemianopia between parietal lobe and occipital lobe. What is the difference?
Because that part is double, so macular sparing is there.
Macular sparing. So occipital lobe, they will be involved the macula, but in parietal lobe homonymous, there will be macular sparing. Good. And also this occipital lobe is an area for balance and posture, all these things. This is I have put this slide, is a CSF drainage. There is a CSF, how it is produced. It is produced from the choroid plexus. That is a left ventricle and right. There is a central ventricle, two lateral ventricles. They meet from the third ventricle reaches the fourth ventricle, and the fourth ventricle, the apertures are there. Fourth ventricle, it goes to the subarachnoid space. And this is where the cerebral fluid is produced from this choroid plexus, the red radius. They produce the CSF, and this is subarachnoid, from the subarachnoid space, this CSF is drains into the superior sagittal sinus. So brain has parenchyma, its vascular supply, its venous drainage, its CSF supply. So this superior sagittal sinus is a vein of the brain. Almost all strokes are arterial strokes, but very few percentage of cases there may be a venous stroke also. Yes. Yes. So this superior sagittal sinus is a thrombosis of superior sagittal sinus thrombosis. Vein thrombosis because mostly maybe due to infections, meninges infections, or otitis media, or infections on your sinuses. This venous gets affected and thrombosis, or it may be thrombus due to hypercoagulable state. Protein C, proteinase deficiency, antithrombin 3 deficiency, etc. are there. They are hypercoagulable state. These are the common causes for venous thrombosis. And if the superior sagittal sinus vein is thrombosed, one cerebrovascular accident occurs. Actually, you see, the brain, the arterial supply is totally divided. Left-sided artery supply and right-sided artery supply is different. But about venous drainage, there is not right and left this choice. Your superior sagittal vein is drains both left side of the half of the brain and the right side half of the brain. It is unlike arteries, which is very much distinct, left and right. So, if the superior sagittal sinus is thrombosed, maybe it is manifested maybe in the both sides of the body. So there are few 2-3 conditions where at the arterial obstructions are always manifested in the one half of the body. But the superior sagittal venous thrombosis may be manifested in the both sides of the body, and you know that cortex. I will come to the later. There is in the middle there are 2 legs are there. If you follow the prefrontal cortex, 2 legs are there and the head is downside, no? Right. Yes. The legs are represented in the middle, in the motor radii. If the superior sagittal is thrombosed, there is chance of both legs are affected. Got my point? You got my point? Both legs are affected. This is one is the rarest cause where the paraplegia can caused by cerebral cause of paraplegia. One is the rarest cause of cerebral. Another cause you told already is the undivided anterior spinal artery. Undivided. Because there is a anterior communication. No, there is no chance. But if there is undivided anterior spinal artery thrombosis, it may cause paraparesis. These are the very few causes of paraparesis due to central cause. Paraparesis is always due to spinal cord lesion. But there are few rare causes. Anyway, so this is the system. Now, this is part of the brain, you know that the cranial nerves, how it is distributed. This is the cranial nerve, 2 to 4, 4 is the 2 is the forebrain, and 2 is the midbrain, and 3 is the pons, and 4 in the pons, and 4 in the your medulla. This way, this cranial nerve motor nuclei are distributed. You know all these things. I am not going to. If you do a cross section in the middle of the midbrain, what you will see? There is a expected what in the midbrain? You expect there is a the third and fourth nerve is there. There is a trochlear nerve there. Internal colliculus, lemniscus. Lemniscus is the you know that the posterior fibers. Posterior fibers. In the lower part of the medulla, there is a nucleus gracilis and nucleus. Posterior fibers, they relay there. After they form the medial lemniscus, and that goes into the upper side of the thalamus. So medial lemniscus is the representation of the posterior column fibers, and there is a dictum, you know, there is a cerebral peduncle, you know all these things. So these are another is dissociation of superior cerebellar peduncle. This midbrain is pons, and there is a connected with the cerebellar tissue by different peduncles, superior peduncles, and there is a Frontal, these books into the trochlear nerve nuclei is there, mesenteric nucleus, and corticospinal and corticonuclear fibers. Here the corticospinal tract is in the side of the brain. Here it is not called crossed yet. It will cross at the lower of the medulla. Corticospinal tract will cross at the lower of the medulla and goes to the opposite side. Okay, you know all these things. The corticospinal tract, they from the prefrontal cortex, it comes down corona radiata to internal capsule. Internal capsule, it is very much compact. Then it is coming through the midbrain neurons in the same side. At the medulla, at the lower of the medulla, it crosses to the opposite side. This is very important for your clinical examination. So manifested up to the medulla, the motor manifestation will be mostly in the opposite side. The sensory is same. Sensory is same because there is spinothalamic sensation is a spinothalamic tract and posterior vibrations and positions by the posterior column, and pain, touch, temperature by the spinothalamic tract, and fine touch also by the posterior column. So spinothalamic tract, they cross at the level of the spinal cord or 2-3 level, they will cross it. In front of the aqueduct, they will cross spinothalamic tract and manifested in the opposite side of the parietal. They projected in the there is the parietal lobe. Thalamus is the higher center for all sensation relay. Higher center for relay center is thalamus. Then thalamocortical fibers, they are represented. And similar, but in the posterior column, the sensation of vibrations and position sense and fine touch, they goes to the same side up to the midbrain, up to the lower of the medulla, nucleus gracious and nucleus cuneatus. Then they goes to the medial lemniscus, goes to the upper. These are the sensory and motor fibers they are distributed. So all these fibers will get in the in the midbrain area. And also the nucleus according to the your level of the brain. This is spinocerebellar tract, and also there is the cerebellum is also is part of the brain which is responsible for this your involuntary movements and postures. They are connected with the periphery by the spinocerebellar tract, the peduncles. Through the peduncles, this brainstem is connected with the cerebellum. The spinocerebellar tract from the spine, they through the peduncle, they enters the cerebellum. And the cerebellum is also alters the posture of the body. The motor functions is not only controlled by the corticospinal tract. It is influenced by many things, by your extrapyramidal system, by your cerebellar system. It is influenced. Red nucleus, rubrospinal tract, extrapyramidal part. Yes, that is. This is the that I have telling it is a corticospinal tract. How it is in the there's the leg fibers are in the middle, you know, and the head fibers are at the periphery. And then they meets to the internal capsule. There is a very much compact in the anterior limb. In the internal capsule, they are very much compact. Then they gradually comes to the and they crosses at the level of medulla and goes to the up to the anterior horn cell, relay in the anterior horn cell of the spinal cord. And an anterior horn cell, from anterior horn cell and onwards, it is a lower motor neuron. Onwards up to the muscle spindle, it is a lower motor neuron. From the brain up to the anterior horn cell, it is the upper motor neuron. Good. So, this is another section for midbrain. You get there is a third nerve, nucleus is cerebral, and the red here is the red nucleus. Red nucleus is a part of the extrapyramidal system, and it goes by rubrospinal tract. It connects with the affects the motor functions. It is a part of the extrapyramidal system. The substantia nigra is there. The substantia nigra and the substantia nigra, the neurotransmitter in the substantia nigra is dopamine. If there is deficiency of dopamine, it causes Parkinson's disease. That Parkinson's disease, you know, the manifestation, there is flexion, spasm, hesitant gait, etc. are there, and there is frequent falls may be there. So these are and red nucleus. There are some few symptoms are there. You will have to remember. But sometimes some examiners like this. Do I don't? But suppose it is a Weber syndrome. Means 6 nerve nucleus of the same side and the corticospinal tract of the opposite side. Yes, and it is a Weber is a third nerve. Third nerve is the same side and the opposite. And Millard Kubler, it is a 6th nerve on the same side and the opposite side. Similarly, third nerve and red nucleus affected. It is also called clot syndrome. So, third nerve in the same side, red nucleus in the opposite. So, third nerve nucleus, there is the eye is affected, there is ptosis, pupillary reaction, and this is third nerve what happens, and there is red nucleus on the opposite side. That is the red nucleus means there is a ataxia. So, one third nerve in the same side and opposite ataxia. Opposite is called clot syndrome, Benedict syndrome. This syndrome is not very much just useful, but you'll have to remember because some examiners they like this. Another very important syndrome is Wallenberg syndrome. That is a posterior inferior pica. This is the posterior inferior cerebral artery. There is the infarction of the medulla. Lateral medullary syndrome. Also, we call it lateral medullary syndrome. Lateral medullary syndrome. It's very important. Yes. Huh? What is yes, that is probably medial there is lateral medullary syndrome. It is a medial medullary syndrome. In medullary syndrome, extra is lateral medullary syndrome. Usually 12 nerve is not affected. That's the only difference. Lateral medullary syndrome is very important. It is a common phenomena, and the features are very much academically important. But medial lemniscus is important because it involves the 12th nerve. Lateral medullary syndrome usually do not involve the 12th nerve. Yes, it is in the middle. So, these are the things in there. And there is another cerebral aqueduct. The cerebral aqueduct and the superior colliculus. Then there is colliculus. The superior colliculus, the inferior colliculus. Superior colliculus is involved with conjugate eye movement, and inferior colliculus is associated auditory. Your response to auditory. If you look at the sound. That is controlled by the inferior colliculus. But look at the visual impulse. Light is on, just look it. It is a superior colliculus. So, these are the centers of the brain. But conjugate eye movement is a very important and very, very complicated things. If we get any class later, we will explain this. There is a saccades. There are saccades and pursuit. Saccades and pursuit. Saccade is a quick movement. Suppose you are going by a train, saccades. This superior colliculus is very important for controlling this in saccades and pursuit. Saccade is a quick movement, you just fix the object. After that, when you are in a moving train, if you fix the object, it is very quick. But if you follow the object, it is not that quick. That is pursuit. The quick, just very simply explain that the first movement is saccade and the follow movement, slow movement is pursuit. These movements are all in a moving train. You can fix the object. The train is moving, you are moving, but you can fix the object for a certain little time. The object that is only possible because of this collicular superior colliculus and its connection above. So, these are the arterial supply of the brain. This thing, this thing, all these things. Anterior spinal. We are talking about anterior spinal arteries. There is anterior communicating artery. Anterior spinal artery proximal to the communication is called A2 segment, and distal to the communication is called A1 segment. This and that, this is the carotid artery, and carotid artery is the middle meningeal. This is a middle cerebral artery. Middle cerebral artery is the most important artery because most strokes occurs, and it is the most wide bore artery, and most symptoms occur due to middle cerebral artery territory. So, you have to learn it middle cerebral artery and posterior cerebral artery very carefully because strokes anterior cerebral artery is rare. Because there is a communication between the two, one can go to another side. So, if the one side is obstruction, the blood will if it is a lower segment, it is a proximal to communication, there will be no symptom because the blood will go from the communication to the other side. But if it is only due to distal to the communication, there may be some symptoms, frontal lobes anyway affected. But then middle cerebral artery also it has a M1 and M2 segment because it is divided into a anterior and posterior branch. Before it is divided into anterior posterior branch, it is called M1 segment, and the anterior division is the main artery, which is a continuation of the main artery. So, if the embolus enters in the middle cerebral artery, there is 90% chance it will go to the anterior division because anterior division is the most wide bore and straight. Posterior division is a little bent and goes downwards to the temporal-parietal side, and the anterior division goes to the frontal and parietal side. So, there is chances there. But important part is that the question is this is the M1 and M2 segment. One important question is that you know that internal capsule. It is often the internal capsule is supplied by lenticulostriate branch of arteries. Lenticulostriate is the branch is the direct branch of the M1 segment. M1 segment is direct some lenticulostriate branches. They supply the internal capsule because most strokes we see are mostly due to the internal capsule. So, embolus directly enters into the middle cerebral artery, it gets the lenticulostriate artery, goes straight into it. But if it goes further forward, then it will go to any part of the cerebrum. In that case, the lesions will not that compact because the fibers will be dispersed at the cord. Right, fibers will be dispersed. Only compact fibers they will get at internal capsule. So this is a middle cerebral artery, is a M1 and M2 segment. Now come the posterior cerebral circulation. Posterior circulation, you know there is a vertebral artery. The two vertebral artery meets the basilar artery. Then basilar artery, there are superior cerebellar artery and the anterior inferior cerebellar arteries are there. There are pontine arteries from the basilar artery, and basilar artery divides into two posterior cerebral arteries. This posterior cerebral artery also has a P1 and P2 segment. Before it giving the posterior communicating bed, it is a P1 segment. After it giving the posterior communicating bed, it's called the P2 segment. P2 segment. From P1 segments, it usually supplies the central part of the brain, the medulla, and there is a midbrain, medulla, and inferior surface of the cerebellum. Sometimes supplies it, but in the distal part, they will supply mainly in the P2 segment. They supply some part of the cerebellum. Like that, but here most important is what he was mentioning. He was the posterior inferior cerebral arteries because it supplies the midbrain, it supplies the medulla, lateral surface, and also the inferior surface of the cerebellum. It produces peculiar symptoms, lateral medullary syndrome, what you are calling about. So the vertebral artery, you know, the vertebral artery has only branches. Vertebral artery is the branch of which artery? Vertebral artery, can you tell? Huh? No. Vertebral artery is a branch of the first part of the subclavian artery. Huh? Yes. Subclavian artery is divided by scalenus anterior into scalenus first part, second part, third part. So, is the first part is the first part of the branch is subclavian artery. One clinical importance is there. With that, that is a Stilling syndrome. Still syndrome. But one important is there. The clinical importance is there. Sometimes we in the carotid artery, whether there is any thrombus or not, sometimes we hear that there is any carotid buoy or not. But at the vertebral artery is the first part of the subclavian artery. It is not very deep. Later it goes deep. Later it goes to the vertebral foramina and goes deep. After that we cannot palpate the vertebral artery, you cannot listen the vertebral artery. But at the middle, if you auscultate, if there is a vertebral artery obstruction, vertebral buoy hearing is clinically possible. If you hear it in the lower medial 2/3 or medial 1/3 and lateral 2/3 junction of the clavicle at the root, vertebral artery buoy it may be audible because it is not very deep at that part. It is only the first part of the subclavian artery. It is just has emerged. Just after a few centimeters, it will go deeper. It enter into the vertebral foramina. Then there you will not cannot hear it. And at the fourth, is the fourth, the vertebral artery has no branches there. Only branches of vertebral artery is at the fourth segment. After it enters into the brain, surface of the inferior surface of the brain, it has only branches like that. This posterior inferior cerebellar, it is an important branch for this posterior inferior cerebellar arteries, and anterior spinal arteries. It goes to the. So another now this is the part of the brain. This middle. I just told you this middle cerebral artery that is divided into superior inferior. Middle cerebral artery distribution is separately shown because it's very important for clinical purpose. Middle cerebral artery is the M1 segment and M2 segment. And it's very important for your treatment purpose. Later we'll see that if there is a M1 segment thrombus, we can do thrombectomy. You can approach it from carotid artery. You can do thrombectomy, but in M2 segment, thrombectomy is difficult. You cannot approach it. Then only thrombolysis is the way. Thrombolysis is the way. So more proximal lesion in the middle cerebral artery, some cases thrombectomy may give a dramatic result. Thrombectomy is possible, but in the peripheral lesion it is not possible. Only thrombolysis is a way that will come in when we will discuss about the management will come. This is another sinus. Sinus about venous is a cavernous sinus. You know, cavernous sinus is very important sinus because it is affected by your sphenoidal sinus infections. Thrombosis, cavernous sinus thrombosis. Cavernous sinus is very important structures. Third, fourth, and sixth nerve. These are ophthalmic and maxillary division of the trigeminal nerve, and also the carotid artery. All these are the branches. All these things are found in the wall of the cavernous sinus, and it is very. Previously, it was very common before antibiotic era. Now it is rare, but it is still there. It is common. Most common cause was the sphenoidal sinus infections. But again, it is a if it is a hypercoagulable state, you can get thrombosis anywhere in the body, anywhere in the body. So here is also possible that cavernous sinus thrombosis can occur, and that can give rise to the cranial nerve lesions and trigeminal nerves. So these things I was discussing about the venous drainage of them. There is a supracervical sinus, important clinically. There is this cavernous sinus, and so there are lateral sinuses that also in the falx cerebri, the lateral sinuses that can also get thrombosed, and anyway. So because your vascular supply vascular supply means the arterial supply and venous supply, that I wanted to give importance. The anterior circulation is already I have discussed, middle cerebral artery, MCA, lateral cerebral hemisphere, frontal pole, or is already discussed by in the previous. Pyramidal system functions voluntary and skeletal components. You know, is upper motor neuron, is a cortex, all these things have been discussed. Lateral corticospinal tract causes the medulla, I have already told. Axial and trunk muscle, this is a corticobulbar tract, axial trunk muscle, called axial and trunk muscle. And there is also called a few fibers. Most of the fibers go to the corticospinal tract, but few fibers comes to the anterior spinocerebellar there is an anterior corticospinal tract is there, few fibers, they supply the axial muscles, because if there is a lesions in the internal capsule, some axial muscles spared because they comes to the anterior corticospinal tract. So background and lesions features out of upper motor neural lesions, you know, this is a features, there is spasticity, because there is no control over the local spastic tone. Spastic means there is increased tone. Tone is the monosynaptic reflex. It is controlled at the level of the vertebra. It is just at input anterior horn cell goes to the spindle. It is a monosynaptic reflex, but that monosynaptic reflex is influenced by the corticospinal tract. When the influence is gone, there will be more spasticity. It is called spasticity, increased tone, spasticity. So there is increased jerks. Same thing, jerks is cannot be controlled by corticospinal tract, so it is increased jerks. And Babinski sign positive. There is a withdrawal reflexes becomes positive. Primitive reflexes becomes apparent in these lesions called Babinski sign positive. Now, it is the extrapyramidal system. I already discussed that this motor system is affected by, it is influenced by the extrapyramidal system. It includes the basal ganglia, putamen, substantia nucleus, substantia nigra. We have seen in this cross section of this midbrain. There is a substantia nigra, there is red nucleus. And in the brain, in the internal capsule, you know, at the internal capsule, in the middle part, there is a there around the internal capsule, this pudate nucleus, basal ganglia, caudate nucleus, and putamen. These are all around the internal capsule. Is there? These are the extrapyramidal system. And there are vestibulospinal, tractospinal. These tracts are there. This also controls the motor activity. Cranial nerve nuclei, I have already discussed how these cranial nerve nuclei are. There is a 2244 Edinger-Westphal nucleus, and this is a motor nucleus. Edinger-Westphal nucleus, you know, there is a nerve for parasympathetic to people. Okay, how the sympathetic supply to the people is parasympathetic causes what? It causes constriction. The sympathetic supply, how it goes to the iris? It is sympathetic supply from the sympathetic trunk around the vessel. That is important. It is around the ophthalmic artery. It is wrapped around the ophthalmic artery and goes to the iris. Yes? It's a just a wrap to the carotid artery goes to the ophthalmic artery and goes to the sympathetic system, goes like this to the reaches to the iris. This is important. And parasympathetic through adenoidal nucleus. This is a constant. Superior salivary nucleus, these are the all motor nuclei. Apart from these cranial nerves, other motor nuclei also there. Motor nuclei are the grey matter. Motor nuclei means they are grey matter, and the dendrites and others are white matter. These are the other grey matters. They are found in the parasympathetic superior salivary nucleus. This is parasympathetic to lacrimal, submandibular, and sublingual glands. Nucleus solitarius, that goes to the 8th and 9 and 10 nerve. Taste. The nucleus of tractus solitarius, there is a higher function for taste, that the fibers goes through this 9, 7, it is not actually it is not 8, it is 7. Nucleus of tractus solitarius, taste sensation, how it goes to the tongue, anterior 2/3 by the chorda tympani. Chorda tympani is visually it is a branch of the facial nerve, but the fibers coming from the trigeminal. Visually it is a facial branch, but fibers coming from the nucleus of tractus solitarius through trigeminal nerve enters to the chorda tympani. Yes. Higher center for taste sensation, nucleus of tractus solitarius. From that fibers goes to the trigeminal nerve and glossopharyngeal nerve. Trigeminal nerve through chorda tympani supplies anterior 2/3 and through glossopharyngeal supplies posterior 1/3. So anterior 2/3 by chorda tympani, visually it is a branch of facial nerve, but fibers coming from trigeminal, and posterior 1/3 is supplied by glossopharyngeal, fibers coming from nucleus of tractus solitarius, because it is the only taste sensitive fibers from in the midbrain, in the lower brain, medulla, pons and medulla. Some nucleus is very long, no? Trigeminal nucleus, the sensory nucleus is very long. It goes deep up to the medulla, because it is in lateral medullary syndrome. I was telling, the sensory of the face is affected. No? Sensory face is supplied by trigeminal, but it is affected in the medulla, because the sensory nucleus of the trigeminal goes out deep into the medulla. Facial, sensory, trigeminal. It is started at above, but it goes deep into the middle. Once it starts with but sensory medullary syndrome, we get the facial paralysis. One side. Balaclava, there is a balaclava anesthesia. Balaclava anesthesia, what is this? It is the anterior face. Anterior face is supplied by the trigeminal nerve. Is a trigeminal nerve, and it is and then there is anesthesia in the anterior part of the brain. Posterior part is spared, but posterior part of the face is supplied by it goes to the spinothalamic tract. From above it comes down, and again it enters the spinothalamic tract. It is a facial fibers on the posterior part. If you put a helmet, balaclava helmet anesthesia, balaclava helmet is like this posterior part of the face, posterior part of the face, this part, just around the auricle and also this part. Posterior of the face, the fibers directly come through the brainstem, it comes down and enters the spinothalamic tract. It goes up. But anterior part is go through the trigeminal. That's why it is a lateral medullary syndrome. There is a balaclava anesthesia. Anesthesia is in the posterior part, in the anterior part. Posterior part is spared, because posterior part where goes directly to the spinothalamic tract, not through trigeminal. Explain, no? That's right. So these are the dorsal this is a nucleus ambiguous. The nucleus ambiguous, it also supplies the motor to the pharynx, larynx, muscles of mastications, muscles of deglutitions. Goes through 9-10 neurons, and the motor nucleus is in the nucleus ambiguous. That is also affected in your in the medulla. Lateral medullary syndrome is nucleus ambiguous also affected. And there is paralysis of this motor nucleus. Yes. Dysphagia, motor nucleus. Dysphagia is a motor supply to the pharynx and larynx. Right. Already 11 o'clock. Sorry. You have a class afterwards? OPT, no? হ্যাঁ, ঠিক আছে, চলো চলো আমরা তাড়াতাড়ি শেষ করি। ওকে, then inferior salivary nucleus, parasympathetic, the parotid gland. This is the motor nucleuses. And pathogenesis of the hemorrhagic stroke already told, it is the hypertension, the aneurysm rupture, AV malformation, and amyloid angiopathy, right. Pathophysiology, you know, there is a mass effect I have already discussed, increased intracranial pressure in case of subarachnoid hemorrhage and hypertension, and herniation. Herniation, I have already told you how herniation occurs. Pathophysiology is ischemic stroke, there is atherosclerosis, there is stroke, and there is a embolism and atrial fibrillation. Atrial fibrillation is a cardiac embolus, thus discharge goes to the system hypertension. Usually in atrial fibrillation we get a stroke, an arterial stroke, because thrombosis is in the left side of the heart. Left atrium is the common site for thrombus. But if any venous thrombus can go to cause stroke, in venous, suppose there is a deep vein thrombosis, can it cause stroke?
Theoretically is possible.
How? Because it will, from the right heart, it will go to the right heart. From right heart go to the pulmonary artery. Pulmonary, it is stuck into the pulmonary circulation.
Pulmonary embolism.
Pulmonary embolism. It will not cause stroke unless there is a communication between left and right. Like
Paradoxical embolism.
ASD or VSD, it should go to pulmonary infarct, not arterial infarct. Unless there is ASD, VSD, it is possible. It is possible. So it is a cytotoxic edema. You know, there is a pathophysiology radical injury. Risk factors for stroke is hypertension, diabetes, smoking, and age. You know all these things. And dyslipidemia, and atrial fibrillation, and obesity. These are the genetic risk factors for this is theoretically important. That this CADASIL is theoretically important. There is a genetic defect that people do. We can discuss it if there is a early stroke, early onset stroke at early age. Then these genetic predispositions to be discussed in details. But just for now, you can remember these terms, right? CADASIL is a genetic transformations that predisposes to stroke, and there is familial hypercholesterolemia. There are genes for dyslipidemias, and there are genes for ACE inhibitors causing hypertension. So there are genes for ACE inhibitors, genes for thrombosis, genes for this CADASIL, all causes the early stroke. When we will discuss a stroke at an early age, we can discuss the genetic predispositions more. Here the same things, yeah, we have already discussed it, that how this sensory tract and motor tract, this goes on. These are the same parietal cortex in how it is represented. You have already discussed the motor and sensory tracts. How they goes like this. Joint position vibrations to the posterior column, pain touch temperature to the anterospanothalamic tract, and fine touch posterior column. These are the connections when you say this medulla and cerebellum, anatomy of the brain stem. Lateral medullary syndrome, we have discussed it in many times, different nucleus, how it is affected. This is another section of the brain at the level, you know, this other than this cerebrospinal tract and all these things are there. All these tracts, about all these tracts are already discussed.